Everybody who's experienced a diagnosis of cancer wants that four-letter word cure, because we have all been brought up with the idea that cancer is a fatal disease unless it can be cured. And that binary concept, that black and white, either you're cured or it kills you, is driven into us from the time we ever hear the word cancer. And it's true for patients, it's true for physicians, it's true for everybody in the medical profession. That's what we seek, is the cure. Right? And the summary of my presentation today is that that's very naive and never has been true for thyroid cancer. And as it turns out, it's probably not true for most other, perhaps any other cancer. Because I think all of us, all the time, are likely living with some cancer in our system. And that's whether you've been diagnosed with it or not. And you live with it, and at a low level, your body handles it and controls it, and you're never, ever going to be cured until you're dead. Okay? Just as I will never be cured until I'm dead either, even though I've not been diagnosed with the cancer. And that's a concept that we have to get our minds around. It's a philosophy that challenges the preconceived notions of your providers. And it's an important concept for all of us, because in the futile pursuit of a cure, I've seen far, far too many of my patients being injured and damaged in the process of seeking something that is so elusive it can never be found. This is a woman. She's 29 years old. She has a lump in her thyroid, and you can maybe just see it there. I don't have a pointer, but here. That's a thyroid nodule, and that thyroid nodule was biopsied, just as many of you have experienced, and the diagnosis, papillary thyroid cancer. Okay? And so we set off on a path, we set off on a journey that you have been on, or many of you or people you know have been on. We say we want to cure your cancer. And so we remove the primary disease. We go in and do surgery to remove that thyroid. And we remove any invasive disease. The margins were negative on the pathology. And we remove all of the involved lymph nodes. In fact, there's a lot of push over the last 10 or 15 years to completely clear out the lymph nodes of the neck in order to eliminate all of those tiny specks of disease that we know are commonly there in the lymph nodes. And there's a huge argument in the profession, especially among surgeons, how extensive should the lymph node dissection be in papillary thyroid cancer? Should this be a prophylactic, meaning we don't even know there's disease there, but we're going to take everything that might contain disease? Or should we simply only take out the stuff that we know about? Because the more we take out those lymph nodes, the more we find microscopic specks of thyroid cancer hiding out in those lymph nodes. And surely it must be good to get rid of that cancer. If you're ever going to cure it, you have to get rid of the cancer. There's another reason to try and get rid of all of that disease, and that is to make it easier for radioactive iodine to work, right? So after the surgery, we give radioactive iodine to kill off any remaining cells that might be there after the surgery. Again, in the pursuit of a cure. And the goal is to minimize the disease recurrence rates. We don't want you to have a recurrence later on. That's a really bad thing to have. And we want to be able to enable accurate staging. If we don't take out those lymph nodes, how do we know that you're a stage 4A disease or a stage 3 disease instead of stage 1? And of course, we also want to enable long-term surveillance, because if we're going to have a recurrence, we need to find it early to protect you from the damage. But there's one missing step in there, and that is minimize morbidity. What is morbidity? Morbidity is the damage we do to you in the pursuit of the cure. And that morbidity is significant. I think some of you will have experienced hypoparathyroidism, which is at best a major pain in the neck, because you have to manage your calcium levels, and you have to adjust your calcium intake and your vitamin D intake, and you have to monitor for kidney injury, and you're getting 24-hour urine collections done every so often in order to monitor that, or you should be. Some of you will have experienced voice changes after surgery, because the more extensive the surgery, the more likely it is we're going to damage the nerves on the back of the thyroid gland, which are the control mechanism for your voice. And if you come out from the surgery a little hoarse, if it's in the pursuit of cure, sometimes we say, well, that's the price you paid for being cured. But it's still a significant impact on your life. It's a significant impact on your quality of life at the very least. And if you were unfortunate enough to get both nerves damaged and you land up with a tracheostomy permanently, unable to speak, it's a major catastrophe for your life. Okay? It doesn't happen often, but it does happen too often in this country that somebody lands up with a tracheostomy. But why do we need it at all? Why do we need any of those things? And why do we need to then monitor afterwards? If we've done all this stuff with radioactive iodine and surgery and we've taken out everything that could possibly be there, why do we even need to bother with surveillance? Well, at the end of the day, we need to bother with surveillance because not everybody is cured. In fact, I would argue maybe most of us are not cured. These are the survival figures for thyroid cancer, papillary thyroid cancer, the most common type. Mayo Clinic data, some of the best data in the world, tracked and monitored patients over about 30 years of follow-up. In fact, some patients have been followed for 65 years in this data set, following their diagnosis of cancer. And what you can see is if you're fortunate enough to have stage 1 cancer, that's the white line at the top, you're pretty much guaranteed to live forever. Okay? So that's a 99.7% survival at 25 years of follow-up. That's pretty good odds. And that's why people sometimes say, hey, this is a good cancer. Yeah? If it's going to make you live forever, it must be a good cancer. So stage 1 disease looks really good. Stage 2 disease, the red line, is also pretty good. It's about a 98%, 97% long-term survival for stage 2 cancer. It's pretty good for papillary cancer. Stage 3 disease, which is older people with either invasive disease from the thyroid out into the surrounding tissues or lymph nodes involved in the central part of the neck after the age of 45. That's the little yellow line there. And you can see stage 3 disease, it's not quite so good. It's about 20% of people with that condition are dead within about 10 to 15 years. It's a slow killer, but it does kill some people. And of course, stage 4 disease, and these are historical data before we had any chemotherapies available for thyroid cancer, but you can see stage 4 disease kills people. And in this study, people with stage 4 metastatic thyroid cancer were all dead within about 10 to 12 years of their diagnosis. So, good cancer, it sometimes gets called. It's not so good if you have metastatic disease. Okay. Now again, a couple of things I would emphasize. That stage 4 disease is only people over the age of 45 when they're diagnosed. So distant metastatic spread in older people is bad news. Distant metastatic spread in younger people, not nearly so bad. Okay.
The stage 4.
Yes.
So there's some quirks in the staging where 45.1-year-old with a single lymph node is a stage 4. She was 44.9 years old, and she had the same disease. She's stage 1. So I think there's a discontinuity in the matrix here.
You and me both. It's madness. It's total madness. And that's why we don't actually use the staging as our real determinant of what prognosis is. There's a quirk, as you're pointing out, in the American Joint Commission on Cancer and the International Union Against Cancer in their setting up of the staging system. What they were trying to do was to say people younger than about 45 carry a pretty good prognosis no matter how extensive the disease is. So let's at least not call them stage 4 when they have metastases in the lung. Because young people with mets in the lung respond very nicely to radioactive iodine and to TSH suppressive therapy, and they continue to live for decades. In fact, most of them have a normal life expectancy when they're diagnosed young. So let's not call that distant spread stage 4. Let's call it stage 2 instead. And it was that desire that drove to this slightly crazy notion that if you're diagnosed on your 45th birthday and you have a lateral neck lymph node involved, you're going to get stage 4A. But if it's the day before your 45th birthday, then you will not be so diagnosed. In fact, I accelerated the diagnosis of a patient that we kind of knew had cancer, and she was scheduled to have her biopsy done on her 45th birthday. And I said, really bad idea. Let's bring you the day before, get that biopsy done. At least we know then. And so we had her stage 1 instead of stage 4A.
45-year, 2-month person with 4A cancer?
Yeah.
Thank you for doing that.
Yeah. Well, you know, language matters. And when we use these staging systems, especially with the new version of that says 4A is nodal disease, we convey a really bad message to our patients. I want to emphasize this stage 4 is really stage 4C in the modern idiom. These data were in the previous version of the staging where you didn't include those lymph nodes as stage 4. So this is distant metastatic spread in older patients that carries a more dire prognosis. And again, these are data developed well before any of our new drugs, any of our new therapies. This is historical data, really dating from about the 1990s. But there's a disconnect between living forever, which most patients with stage 1 disease do, and recurrence, which many patients with stage 1 experience. Okay? These are actually low-risk patients by our way of thinking about it. These are essentially stage 1 and 2 patients. Patients with local disease in the neck, but with lymph nodes involved. And what you can see here is that whether you do or don't receive radioactive iodine, at the end of the day, if you have disease that involves lymph nodes, you've got about a 20% chance that you're going to have a recurrence of your thyroid cancer over the course of the next 20 years. Okay? That's a 1 in 5 chance from the outset that you're going to have a recurrence. Now, normally, we would think of recurrent cancer as being a death sentence. Okay? If you get recurrence of your breast cancer, the chance you're going to survive that is much lower. If you get a recurrence of your colon cancer, the chance you're going to survive that is much lower than if you never had that recurrence. But the odd thing about thyroid cancer, especially well-differentiated thyroid cancer, papillary follicular thyroid cancer, if you have that 20% chance of recurrence does not translate into dying. Okay, you get your recurrence, we handle the recurrence one way or another, and you still are going to live forever if you're stage 1, stage 2, or even stage 3 disease. You're going to live forever. And so we've got to get away again from this concept that a recurrence is a disaster. A recurrence is an inconvenience in this disease, and it should be treated as such. We should be watching for it, we should be monitoring for it, we should be doing what we call surveillance for it, and when we find it, we should treat it and we should move on. Because this is almost always lymph node disease in the neck that actually was left behind at the time of the original surgery, that was not destroyed by the radioactive iodine, that was not suppressed completely by the TSH suppressive therapy, and which then showed itself at a later time, either because it grew a little and we could see it, or because our technology got better and we could find it. And it's very interesting that a fair number of patients that I've seen over the years have been told they're cured. They have an undetectable thyroglobulin negative ultrasound, and then at some point the thyroglobulin becomes detectable. And we say, oh my goodness, you've gone from undetectable to detectable, and therefore you have a recurrence of your thyroid cancer. Bad news. In those cases, not uncommonly, the reason that they've developed a detectable thyroglobulin is because the thyroglobulin test got more sensitive. In fact, there was several transition points that I've experienced over my career of 20 years when we have gone from a thyroglobulin with a lower limit of detection of 2 to a lower limit of detection of about 0.5 to a lower limit of detection of 0.1, now to 0.01. Okay, and every time we shift the goalposts, every time we get a better test, we find a whole bunch of patients that we thought were cured, and lo and behold, we've got detectable thyroglobulin, which means some amount of thyroid tissue, presumably thyroid cancer tissue, hiding out in their neck somewhere. And every time we change the assay, we find a bunch of patients who we thought were cured who were not. So cure is an elusive concept in this disease.
Doctor, on that last slide, what was the y-axis?
The y-axis here is 100% of patients with no recurrence, and then down to 80% of patients with no recurrence. Yeah. So this is the absence of recurrence. In other words, patients in remission. Okay. And that word remission is an important one, and that's actually the word I use. I don't tell patients I'm going to cure them. I say what we're aiming to do is control the disease, drive you into remission, keep you in remission until we can call it stable remission, and drive it towards long-term stable remission, which in my definition is no evidence of disease for 10 years or more. And then at that point, we transition from long-term stable remission into long-term boredom. Okay? And boredom is a good thing in this disease, because if I can't find anything at the end of 10 years, realistically, whatever is left is not going to harm you. And that's really the key. Risk of recurrence, in reality, reflects the growth of residual cancer. And I think this is a word that's misused, this idea of recurrence. You've got a recurrence of your thyroid cancer. Almost always it's not a recurrence. Almost always it's a residue of thyroid cancer that was left behind at the time of the original surgery, that was not destroyed by the radioactive iodine, that was not killed off by the TSH suppression, and which is still there and still viable. And over the years, gradually, progressively, that little spot of cancer has the potential to grow. It doesn't always grow, but it can. And if it grows to a point where we detect it, and we start to talk about recurrence, and that has a bad implication. If we think about it as residue, then perhaps the implications are not quite so severe. Very clearly, that growth of residual cancer is most likely to happen for people who have a bunch of disease left behind. If I have to saw through a bunch of roots of cancer to take your primary cancer out, and we leave a whole chunk of thyroid cancer in your neck at the time of the surgery, then the chance of a future problem from that residue of cancer is much, much higher than if I got a nice clean sweep and got all of that cancer out on day one. And so that's one of the reasons why gross residual cancer, what's known as incomplete surgical resection, sometimes technically an R1 or an R2 resection, is the way it's defined in the staging system. Those things, of course, increase your risk for recurrence. And those are the reasons why radioactive iodine is often used. Radioactive iodine is used to act as weed killer, to kill off the remaining roots of the weed of the cancer. But unfortunately, radioactive iodine is pretty weak stuff. It doesn't really have a huge impact on residual cancer in the neck. And it's definitely been overpromised and under-delivered on its capacity to control cancer over the years. Nonetheless, we do use it in those high-risk settings to try to improve the chances that we'll kill off the remaining cancer and decrease your chance of future recurrence. But the real problem in papillary cancer is the lymph nodes. And the lymph nodes are often involved in this cancer. If those lymph nodes are not completely stripped out of the neck, you're often leaving tiny little specks of cancer behind, and that cancer has the opportunity to grow over the years, to show itself on the ultrasound, to show itself on the thyroglobulin measurement, and lo and behold, we turn up with a, quote, recurrence in the future. But the key point, recurrence and death are two different things. Okay? Just because you have a recurrence does not mean you're going to die of the cancer. And in fact, with papillary thyroid cancer, what really defines your chance of dying of the cancer is based on how it presented right at the beginning. And the development of a recurrence and the need to do another surgery or to do an alcohol ablation or to do something else to treat that cancer is a pothole in the road. It doesn't actually change the long-term prognosis, which is really bizarre. It's different from any other cancer type. And it's one of the reasons why thyroid cancer is so interesting to us in the scientific world. When we're looking for recurrence or residue of cancer, we have to remember where to look. And one of the common mistakes I see recurrent again and again and again is physicians not looking in the right place with the right modalities. So somebody will have had a papillary thyroid cancer, stage 4A, 46-year-old woman with a couple of lymph nodes out in the right side of the neck, and those will have been taken out at the time of the surgery. And so now we've got stage 4A disease. If we have that stage 4A disease and we've taken out the whole thyroid, then it's unlikely that a recurrence would happen inside the thyroid because the thyroid is gone, right? Although that spread within the thyroid is very, very common for papillary cancer. It's the reason that we do recommend take out both sides of the thyroid for a significant papillary thyroid cancer because of the potential spread to the other lobe. Local invasion into the soft tissues of the neck actually quite unlikely in papillary thyroid cancer. More common in older patients, more common with BRAF mutations, but nonetheless the majority of patients with papillary thyroid cancer do not experience invasion into the soft tissues of the neck, and therefore recurrence in that soft tissue is very unlikely. What is very likely, though, is lymph node involvement. Okay, so for papillary thyroid cancers, more than 60% of people at the time of diagnosis have lymph nodes involved, often microscopically. And of course, what the surgeon will tend to do is take out those lymph nodes around the thyroid and maybe do a prophylactic central neck dissection if they're following the last iteration of the guidelines, and take out all those lymph nodes and diagnose you with your stage 4 or stage 3 papillary thyroid cancer, and then treat with the radioactive iodine to stop it coming back. But actually, that's the most common site for the recurrence, is in the lymph nodes, by far. So when I see somebody with a stage 4A designation whose thyroglobulin is 0.5, I know where to look. We're going to find it, and we're going to find it in the lymph nodes of the neck. And it's just a matter of waiting until it shows itself in the lymph nodes of the neck. There's very, very little point in doing additional scans apart from ultrasound. PET scans I see commonly being used in this scenario almost never yield anything for thyroglobulins down in the less than 5 range. CT scans of the neck and chest, again, will use them, but the chance of us finding a distant metastatic deposit is pretty low. And so somebody with stage 4A disease, detectable thyroglobulin, you need to look where the money is, which is in the neck. Because spread to other organs occurs late and uncommonly. And spread to other organs essentially only happens if you have extensive disease, either invasive disease into the soft tissues of the neck where it has the potential to spread to other organs, or extensive and bulky lymph nodes where it can have leaked beyond the lymph nodes into the other tissues. But somebody with a standard papillary thyroid cancer, stage 3 central compartment lymph nodes involved, stage 4A lateral compartment lymph nodes involved, again I'm talking over the age of 45 here, those diseases, if they're going to get a recurrence, it's going to be in those lymph nodes in the neck. Okay? On the rare occasions it does spread to other organs, in papillary cancer it's lungs and bones. Lungs and bones, that's where we should be looking. For follicular thyroid cancer, it's bones, lung, and soft tissue. Similarly with Hürthle cell cancer, lymph nodes, bones, and soft tissue. And then anaplastic, of course, nasty, it can go anywhere it chooses to go. Growth rate, slow for papillary cancer. So that's another lesson we learn, is that with papillary cancer, we've almost always got time on our side because it doesn't change rapidly. So if you have a thyroglobulin of 2 after your total thyroidectomy and your central neck dissection, and we can't find any evidence of disease, don't panic. Follow it for a while and see what happens. If it goes from a 2 to a 5, all right, you're more likely to find stuff, so now you go looking. Ultrasound, if necessary, CT scan. If it goes from a 5 to a 10, you're going to find it. So keep looking, and then when you find that lymph node, treat the lymph node, okay, or treat that group of lymph nodes, because the growth rate is slow. You don't have the luxury of time if you're dealing with anaplastic thyroid cancer. It grows rapidly. Okay, there you have to do everything all at once. But papillary, the other end of the spectrum, you've always got time on your side. And of course, you've always got the option to treat with radioactive iodine, because about 80% of papillary cancers do take up iodine and can sometimes be treated with radioactive iodine. But I have to tell you, the success rate of radioactive iodine in treating residual thyroid cancer is disappointingly low. It used to be felt to be the mainstay of treatment after surgery. I think nowadays everybody's beginning to acknowledge it doesn't work that well. It doesn't mean we wouldn't try it in extreme circumstances, but it shouldn't be relied upon to be effective. And again, important to recognize, papillary cancer, if it involves those lymph nodes, doesn't really change your prognosis. You're still going to live forever. And in fact, at below the age of 45, we don't even include it in our staging system at all. So, how do we survey and monitor thyroid cancer? For differentiated thyroid cancer, papillary and follicular, we use the thyroglobulin. In the past, people have been using stimulated thyroglobulin as well. You get your thyrogen shots and measure how much the thyroglobulin rises. That's pretty much passé now. We don't bother with that anymore because the thyroglobulin assays are so sensitive that you're going to pick it up on the thyroglobulin assay if it's meaningful anyway. And if you take a thyroglobulin of, say, 0.5 and you do the stimulation, it's going to go up to 5 or 10. If you have a thyroglobulin that's 15, it's going to go up to about 100 with the stimulation. And it doesn't make any difference whether you measure it at 100 or you measure it at 15. You know there's leftover cancer somewhere. Okay, so there's not much point in doing the stimulation. So that has pretty much dropped off the radar in terms of the routine monitoring of patients with thyroid cancer. Similarly, the whole body iodine scan has gone the way of the dodo. Nobody really uses the whole body iodine scan for surveillance and monitoring anymore. The only time I would use a whole body iodine scan is if I'm treating a patient with radioactive iodine and I want to track where that radioactive iodine went. So for a post-therapy scanning purposes, I'll use it for that. But as part of the routine surveillance, it's not part of it anymore. Just don't bother with it because we have better tools. And the better tools are baseline thyroglobulin with one of the high sensitivity assays and neck ultrasound scan, because that's where the bulk of the disease is going to be found, is within cervical lymph nodes in the neck. And if I'm struggling and I can't find it anywhere using the ultrasound and that thyroglobulin is just continuing to rise, that's where a CT scan with contrast is really helpful, because the CT scan can look in parts of the neck and the upper chest that the ultrasound can't see. And if I know there's disease there and I don't see it on the ultrasound, I'll use the CT with contrast. It has to be with contrast. And remember, there's nothing wrong with getting contrast, even though it contains iodine. Iodine doesn't feed the cancer. Iodine doesn't do anything bad to you, except if you're trying to treat with radioactive iodine in the few weeks after you receive that contrast material. But by the time 6 or 8 weeks has gone by, all that iodine is out of your system anyway, and you can go ahead and use the radioactive iodine treatment anyway, if you choose to. So never avoid contrast with some preconceived notion that people with thyroid cancer shouldn't get contrast. It's not true. Thyroglobulin testing has become the mainstay of the follow-up of differentiated thyroid cancer, and for good reason. That test has been proven to be very, very sensitive, and as the tests have become better, the sensitivity has become better and better and better. It's very, very specific. In other words, thyroglobulin only comes from thyroid tissue. It doesn't come from any other tissue in the body apart from thyroid tissue. The only place that the specificity breaks down is with thyroid remnants, because after a thyroid surgery, your surgeon will have left a little bit of thyroid tissue behind. They can't avoid it. The only way that you can get a true total thyroidectomy is to take everything out from there to there. And even then, you'll sometimes miss a little thyroid remnant. And that thyroid remnant can then be picked up sometimes on the thyroglobulin, especially as these tests become more and more sensitive. So in the past, we used to think of a total thyroidectomy as leaving no more than about 0.5 gram of thyroid tissue behind in total. And of course, then we would hit it with radioactive iodine to burn out the rest, so-called remnant ablation, and that should get rid of every last speck of thyroid tissue. Well, it turns out not to do so. The success rate of ablation following a total thyroidectomy in eliminating any detectable thyroglobulin is actually probably only around 30 or 40%. Okay? If we define the lower limit of detection of thyroglobulin as less than 2, a stimulated thyroglobulin less than 2, then we can achieve 80% remnant ablation using radioactive iodine after total thyroidectomy. But even with that kind of soft threshold, saying 2 is okay, you're still not achieving that in 20% of patients. Okay, so this idea that you're going to eliminate every last molecule of thyroglobulin, every last thyroid cell from your entire body by taking a total thyroidectomy and blasting it with radioactive iodine, it doesn't work. And the better the tests become, the more often we discover, little detectable thyroglobulin, a level of 0.1 and 0.2. Don't let it drive you crazy, because almost always that's coming from that thyroid remnant that failed to be destroyed. And then, of course, there's the flip side of the coin. Thyroglobulin doesn't always detect leftover disease. It's not a perfect test. There are some people that we'll see who have significant residual cancer, but no thyroglobulin measurable. Okay, so a 0 thyroglobulin does not guarantee you'll never have a recurrence of your cancer, a residue of your cancer. And we see it both ways. So thyroglobulin levels should always be interpreted in terms of the pre-test probability of clinically significant residual cancer. And what we mean by that is if I see a patient with a 1 centimeter completely contained papillary thyroid cancer that's removed at the time of a surgery, no lymph nodes involved, and everything looks clean from the surgical point of view, none of the adverse risk factors, okay, a measurable thyroglobulin 6 months or a year later is a falsely positive reading. The chance that person has thyroid cancer hiding out somewhere that was missed is basically zero. So any thyroglobulin is not meaningful. On the flip side of the coin, if I see somebody who has a deeply invasive, nasty, aggressive thyroid cancer where the surgeon had to cut through it and left some roots behind, and we've given them 150 millicuries of radioactive iodine afterwards, but we know there was chunks of cancer left behind, a thyroglobulin of 0 6 months later is not going to reassure me, okay, because that thyroglobulin may well not be produced by the cancer. There might still be cancer behind, even with a 0 thyroglobulin. So thyroglobulin is good, it's not perfect. And it's why we don't rely exclusively on thyroglobulin in the monitoring. You also want some kind of anatomic imaging. Now, the American Thyroid Association has said that if you have had radioactive iodine following a total thyroidectomy and your thyroglobulin is 0, that you don't need any other testing apart from thyroglobulin. I'm here to say I don't agree with that. I think you do need other imaging, and that imaging should be the ultrasound scan. Because on a regular monthly basis, I see patients in that situation where we do discover some residual thyroid cancer, usually contained in lymph nodes, usually easy to treat, but real disease that is there and real. Sorry, a question, ma'am.
How do you do the thyroglobulin when antibodies are present? How is that, or what's your suggestion?
So in the past, we've just measured it anyway, and we've tracked the thyroglobulin antibodies as a surrogate marker for the thyroglobulin. In other words, if your antibodies are 500, well, probably we won't be able to measure the thyroglobulin protein, but we can track that antibody titer. If it's 500 today, and 6 months from now it's 300, and 6 months after that is 150, then that's generally regarded as you heading into remission, and it's just your immune system is remembering how to attack thyroid tissue. That's the kind of a previous way to do it. More recently, Dr. Spencer in California, who has a big interest in measuring these things, has measured the thyroglobulin using different assays and tried to kind of spin out the antibodies so that she can measure the true thyroglobulin protein. And that's been somewhat effective. It's cumbersome and time-consuming, but it's a little bit reassuring for many patients. But I think the real transition that's happened has been the development of the mass spec assay. This is an assay for the protein thyroglobulin run by mass spectroscopy, which is an analytical tool that's used to discover these proteins, the thyroglobulin protein. And although that assay is not quite as sensitive as the traditional immunoassays that we use, it's getting better. And we can use that mass spec assay on a routine basis. So if I'm seeing a patient where I think their chance of having cancer is relatively low, and I see some antibodies, I don't get worried about it, I just track the antibodies. If I see a patient whose pretest probability of having cancer is higher and I'm concerned about them, they had some of those adverse risk factors I was talking about, then I will go to the trouble of getting the mass spec assay for the thyroglobulin if they have those antibodies present. Okay. It's a useful tool. Those assays are available commercially, so your physicians do have access to those. Quest, LabCorp, and also some of the reference labs like the Mayo Clinic medical labs all have access to those to those thyroglobulin assays. This is the reason that we get a problem with the immunoassays. Okay, this is the thyroglobulin assay. Essentially, your thyroglobulin in your bloodstream is capable of binding to a little plastic bead that's coated with the antibodies to thyroglobulin. And with the radioimmunoassay, what we do is spike your sample with a little labeled thyroglobulin, and we look for the competition between your thyroglobulin in your bloodstream and the thyroglobulin that's labeled. And essentially, the lower the signal, the more the thyroglobulin in your system. And the lower the signal, the higher the signal, the less the thyroglobulin in your system. And that's the way that the radioimmunoassay works. And so we can detect it this way. And I'm just going to flip forward because the key is that if you have circulating antibodies in the blood against thyroglobulin, right, then they can interfere with the ability of that assay to work. And that's the reason the antibodies are a problem for us. The higher the antibody levels you have in your bloodstream, the less sensitive our assay becomes for the protein. But like I say, the mass spec assay basically deals with that. So back to our 29-year-old woman with a thyroid nodule, papillary cancer. She had a near total removal of the thyroid gland. She had central neck exploration as well, and she was found to have a node-positive 3 centimeter, 2.8 centimeter papillary cancer. And after her total thyroidectomy and central neck dissection, she received 100 millicuries of radioactive iodine, and her thyroglobulin post-operatively was 3.5. So she was definitely not cured, right? A 3.5, not acceptable as evidence of cure. And so she had the radioactive iodine treatment, and she had a post-therapy scan, which just showed physiological uptake, a little remnant thyroid tissue, but no signs of distant spread. The uptake was measured at 0.7%. Okay? And what we know about the thyroglobulin after surgery is that it predicts long-term outcome. If you have a thyroglobulin that's 0 immediately post-op, you're going to do really well. If you have a thyroglobulin above about 5, the chance of you having a future problem is high. And we can look at that in different ways, whether it's stimulated or unstimulated, and none of that really matters except what happens to the trend. The thyroglobulin rising is a problem. So by March of 2005, this young woman's thyroglobulin had gone up to 4.7. Okay? So this is thyroglobulin positive, scan negative disease. Her whole body iodine scan was negative, ultrasound negative, CT scan negative, PET scan negative. She had the whole bunch, MRI, bone scan, PET scan, high resolution CT scan of neck and chest. She had consideration of empiric therapy with radioactive iodine. Remember, this is a 29-year-old woman we're talking about here. Node-positive disease. Where is the disease? In the neck, in the lymph nodes in the neck. But in the meantime, she'd had a scan of everything done. This is a $100,000 workup. Okay, chasing disease, we already know is in the neck, right? You just said it. Another round of radioactive iodine, because maybe the post-therapy scan can localize the disease, but it didn't. So what do we do next? She did have that 150 millicuries, post-therapy scan negative, and her thyroglobulin kept going up, 6.3 now. Okay. Where's the disease? In the neck, right? But she had another whole body negative, scan negative, a PET scan negative, a bone scan, a CT scan. What the heck are we going to do? Okay. Remember the biology of the disease. The cancer is in the lymph nodes of the neck. She's 29 years old with a node-positive papillary thyroid cancer. You can actually figure out where the disease is a little bit based on how high the thyroglobulin is. If you have a thyroglobulin less than 10, it's in the cervical lymph nodes. Okay, it's not going to be in the bones. It's not going to be in the lungs. It's going to be in the cervical lymph nodes. So everything is pointing to this being in her lymph nodes. What's going on with my little thing? Here we go. But if you're going to analyze those cervical lymph nodes, you have to do it carefully. And one of the things that you can't afford to do is have a radiologist doing an ultrasound of the thyroid gland when what you're really looking for is an ultrasound of the lymph nodes. And it turned out that in her career of 4 or 5 years of follow-up for this rising thyroglobulin, what her endocrinologist had been asking the radiologist to do was do a thyroid ultrasound. And at least in Florida, radiologists, I think it's true across the country as a whole, but radiologists say, if I'm going to do a thyroid ultrasound and code and bill for a thyroid ultrasound, I'm going to look at this part, okay? Because that's where the thyroid is. If you ask me to do a soft tissue neck ultrasound, different order, different code, different bill, then I'm going to look in these parts of the neck. I won't look in this part of the neck. So it turns out that in Florida and many other parts of the states, if you want a proper neck ultrasound scan, you have to order it as 2 different studies. You have to order thyroid and neck. And looking back at this young woman's history, her endocrinologist had been asking for thyroid ultrasound every single time when she'd gone in because she had thyroid cancer. Thyroid ultrasound, thyroid ultrasound. And so the central neck had been studied numerous times with negative findings. She'd gone through this $100,000 workup. She'd been terrified to within an inch of her life that she might have metastatic disease, and yet you already know exactly where the cancer is. And there it is. The first time she had an ultrasound, in this case at Mayo, we said, hey, look, there's that little rounded thing. And although you may not see it all that well on the screen there, right here is a hypoechoic, rounded, highly suspicious lymph node measuring a total of 1.2 centimeters. It's no doubt been growing progressively over time, and it's in the lateral neck, okay, region 4, right here, the most common site for the recurrence in a low-risk thyroid cancer. 1.2 centimeter, biopsy positive, it was left region 4, okay? So, we've now found the disease. It took us a $500 ultrasound. You just had to look in the right place. You already knew where the right place was. But now we have to decide what to do about it, right? She was 29, she's now 32 or thereabouts. She's got her whole life in front of her. She had stage 1 disease, right? And so she's going to live forever. And she's got another 50 to 60 years of her life ahead of her. We've got options to treat her, but we have to remember the harm as well as the good that we might do. Certainly we've got the option for another surgery. There's some risk associated with that, but it would certainly get that lymph node out and any other lymph nodes around that area. More radioactive iodine. I often say we'll give more because the first round worked so well. She's had 2 rounds already, 250 millicuries. If we just add more and more to that, all we're getting is harm. We're not really getting benefit. External beam radiation. We've been very reluctant to use external beam for thyroid cancer in the past because of the horror stories about the toxicity and the scarring that you get. Actually, modern external beam radiation, not nearly as bad as the old-fashioned stuff. And so I think that the profile of radiation therapy for troublesome disease should probably be rising. But even so, we're reluctant to use it in a 30-something-year-old woman if we've got other options available to us. Chemotherapy. Well, nowadays, of course, we do have chemotherapy available. We used to have nothing. But now we have tyrosine kinase inhibitors that we can bring to bear. But they have significant life-altering side effects. You're on them for the rest of your life, realistically. All that to treat one pesky little lymph node in the neck seems a little excessive, and so we would typically not do it. And so the traditional approach has been either cut it out with surgery or just watch it and observe and see what happens. But we've kind of been watching it and observing and seeing what happens anyway, and our thyroglobulin just keeps on rising. And so we know this disease is progressing despite TSH suppression. So the just watch it approach didn't seem too sensible either. And so I'm hoping this will work. What we elected to do was alcohol ablation. And what you'll see here is in real time, you'll see the needle come into that little area. See the blood flow within that nodule? Right there in the center. And here comes the needle, pop it right in there. You see the needle pop into that lymph node. And now you'll see a little test injection coming along of that little flush, that little blush that happens there is a little test injection of saline, and it'll be followed by some alcohol injection just going into that right now to kill that lymph node. And now you can see there's no more blood flow in that lymph node. Okay? And this is percutaneous ethanol ablation, a technique that was developed by my colleague Ian Hay and myself up at Mayo about 20 years ago now. And we've done now probably between Mayo and Moffitt, we've done probably a total of about 350 patients with ethanol ablation this way for pesky lymph nodes in the neck like this. It hurts, because we're squirting alcohol into a lymph node in your neck and it creates an inflammatory process. So it's not totally painless, but it's a lot less troublesome than surgery. And for appropriately selected lymph nodes, it's very, very effective. That particular patient that we treated had a thyroglobulin go from 6 to less than 0.1. And that was in 2006 or 2007, so we're now about 8 years out from that. And the last time I heard from her, she remained in remission with no evidence of disease. Yes, ma'am?
Question about ethanol. Why ethanol? Is that just a solvent that kind of chews it up?
Yeah, we want to create inflammation in the tissue. And medical alcohol has a long history of being used for this type of purpose. And so we adapted it from the treatment of solid cancerous lesions in the liver to using it in the neck. And we used it first actually in a parathyroid gland and then got the idea to do it in the thyroid cancer. So We're not the only ones doing it. It's been in use now in a variety of different centres around the country, including University of Colorado, including folks in Rhode Island, 2 or 3 other places as well. So there's other groups that have used radiofrequency ablation to achieve the same thing, cryoablation where you freeze it to achieve the same thing. All of those ablative therapies can be effective, but they're appropriate for selected individuals and selected lymph nodes. This patient was ideal for it.
I have a comment.
Yes.
I'm one of your 350.
Hello. Nice to see you. How painful was it?
So it was like a burning sensation,
Yep.
and maybe like a pressure, and it was interesting because they're injecting here, but you feel it.
Uh-huh.
I felt it down here in my shoulder, and I had shoulder pain for like a couple weeks after. But it is the bomb compared to surgery. And no diet.
And did it work for you?
Yes, yeah, I went from, TG jumped from 0.4 to 1.2. They found the one lymph node, they took care of it, and I've been undetectable since 2012.
Right. The success rate of this approach doesn't depend so much on that lymph node, because that one will be killed. The question is, do you have other lymph nodes that are also involved? Because it's not uncommon to actually have a little cluster of grapes in that area as opposed to one solitary lymph node. And so that's where sometimes we'll say, hey, wait and see how it matures over time before we commit to doing anything at all. Because remember, lesson number 1, there's always time on our side for this type of cancer. So we put it off, we track it, we monitor it, we put it off, we track it, we monitor it. But if there's truly a solitary lymph node showing up, especially if it's in an area that's had a previous surgery, especially if you've had all the other available treatments, it's a great option to know that's out there. So back to the original question, when will you tell me I'm cured? I don't like the word cure. Okay, C-U-R-E, 4-letter word, bad language, don't use the word. Okay, I prefer remission, stable remission, long-term stable remission, because we can't rely on an undetectable thyroglobulin. Even if it's stimulated, we can't necessarily rely on it 100% because the more sensitive our assays become, the more we're finding minimal residual disease. The antibodies being negative, of course, also not itself reliable. Even a negative ultrasound, especially if you don't look in the right place, that's not going to be reliable. The whole body scan is not reliable. And then the CT, MRI, and PET scans are not reliable either as a way to say you're definitely cured. So the cure word is a real problem for us. And I think much more important than appropriate than cure is remission, stable remission, long-term stable remission, and boredom. Everyone with thyroid cancer deserves and should receive long-term but low-intensity surveillance. Okay, long-term low intensity. Low intensity because we don't need to be scared of this cancer. There are exceptions to that, anaplastic, of course, other more aggressive variants, and so your level of concern has to be tailored to the disease you faced. But the vast majority of our patients, 85 to 90% of the patients that we see with thyroid cancer have papillary thyroid cancer that is contained in the thyroid gland or within surrounding lymph nodes and can be adequately treated by the tools we have at our disposal. And most of our patients, fortunately, will live forever. What we have to do is to make sure that we don't harm them in the process of trying to cure them. And I think sometimes we do more harm than good in that elusive pursuit. All right, questions? Yes, ma'am.
When you're doing the percutaneous ethanol ablation,
Yes.
does it have to be a superficial node? Is
Nope.
there a certain time where you would say there's too many structures around here, or this is too deep for us to do it? And it would, my other part is, would this also respond to any thyroid cancer like medullary?
So we've primarily gained experience in papillary because it's our most common cancer, and it's especially likely to recur in lymph nodes. Okay, it's residue that begins to grow in those lymph nodes. And lymph nodes are uniquely suited to this type of approach because the lymph node itself is contained in a little, almost like a little canvas sac or a little plastic bag. And so when we squirt the alcohol into it, it reaches that boundary and it doesn't leach out into the rest of the tissue. It's contained. And that's why it's uniquely susceptible to the effects of the alcohol injection. So our most experience is in papillary cancer, and that's where we've had the most success. We have done it for Hürthle cell cancer, for follicular cancer involving lymph nodes, and for medullary cancer, and the success rate is still pretty good, but not quite as good. Part of the reason for that is because these other more aggressive variants typically have more than one lymph node that's involved. And so if we treat one lymph node and kill that one, then a few months later another one shows up in the same area. So we're more likely to fail in that sense. But in terms of treating the lymph node, it's been successful in all of those different cancer types.
So in somebody who has medullary, where you're seeing post-surgery, their 560 calcitonin going from 20 to 25 to 28 to 34, and a suspicious superficial nodule, would you then recommend we would try the ablation rather than just go back in surgically?
A lot depends on the circumstances. Has that region of the neck been operated on before?
Yes.
If it has not been operated on before, we prefer surgery in that circumstance, because realistically with medullary, you're likely to have a multitude of lymph nodes involved in the cancer. So surgery is a better option. If you've had a compartment that's been previously dissected, if you'd had, for example, a neck dissection done, and you get a recurrence in that same area, then we would certainly consider doing an ethanol ablation under those circumstances to try and prevent the need for another surgery. But we would try, especially in the medullary cancers, we would definitely do surgery first and ethanol ablation as a backup.
Do you do a biopsy
Yes.
prior to
Yes.
doing it to make sure?
Yes, my philosophy is I'm never going to do anything without a biopsy-proven cancer. I've seen too many patients go back for surgery, for example, for suspicious-looking lymph nodes, and then they go in and they have a surgery done and we don't find any cancer. And that, to me, is a disaster, because we put you through all of the risks and all of the downsides of a surgery and had no benefit whatsoever. So I think that we should always have tissue, or at least some other compelling evidence that what we're about to treat is cancer. So we'll accept a thyroglobulin washout or a calcitonin washout, for example, that suggests that it's cancer, even if the cytology is negative. But my preference is you have that biopsy up front.
Thank you.
Say again, 5 minutes? Okay. Yes, ma'am. So BRAF has a lot of heat and not much light around it. It certainly has led people to become very terrified of their disease when they learn it's BRAF positive. I think that that's inappropriate. I think we've sometimes overstated the importance of BRAF. What's important to understand is that something like 45% of all papillary cancers are BRAF positive. It's the single most common mutation that drives the development of thyroid cancer. And certainly on the average, BRAF carries the implication of this cancer being potentially more aggressive, because if you take a BRAF cancer and grow it in a petri dish, it tends to grow a bit faster than the BRAF negative cancers, and it has a tendency to be more invasive. But 45% of patients with papillary cancer have BRAF. 45% of papillary thyroid cancer patients don't die of their cancer. You know, it tends to be to have an outcome that is dictated not by BRAF, but by how extensive the cancer is. On the average, BRAF positive cancers are diagnosed a little bit later. On the average, they tend to be a little bit more invasive by the time when they're diagnosed, but everything depends on whether you have invasion, whether the surgeon gets all the margins negative, whether the lymph nodes that are involved are resected, and the presence or absence of BRAF becomes much less meaningful when you take account of those criteria. Does that make sense? Yeah. Yeah.
I guess a concern I have more here for my daughter is you can have the best endocrinologist anywhere, but doesn't so much depend on what the ultrasonographer is doing?
Absolutely.
So how do you have faith that, do you just assume that the endocrinologist is using a great ultrasonographer? I mean, what do you do in that regard?
You know, it's really tough, because at the end of the day, so much of our medical care does depend on faith. You have to have faith in the doctors that you work with. But you're allowed to ask the question. And I would encourage you to ask that question. Number one, are we confident what the radiologist is doing is what you think they're doing? You know, this distinction between thyroid ultrasound and soft tissue neck ultrasound struck me very, very forcibly when I moved to Florida, because at Mayo, we called everything just a neck ultrasound, and they did everything. I went to Florida and came across this kind of discrepancy, and it hit me like a ton of bricks. Because if I hadn't been working in a system that supported my decision making, and actually it was the radiologist who brought it to my attention. They said, you ordered a thyroid ultrasound, but this is a thyroid cancer patient. Are you sure that's what you want? Because what we would like to do is the lateral neck ultrasound. If I hadn't been working in a system like that helped me with my decisions, then I might have been in the same position as this young woman's endocrinologist, elsewhere in Florida. So you've got to be willing to ask the questions. And one of the reasons that you come to a conference like this is to be fully informed. So now you can go back to that endocrinologist and say, hey, when you're doing that order for that neck ultrasound, are you sure you're getting the lateral neck? Your endocrinologist is capable in most places of actually looking at the pictures as well. And I always encourage my fellows and my young colleagues to pull up the images and look at them themselves and make sure they agree with what the radiologist is seeing. And most endocrinologists these days have at least some training in ultrasound, so they can look at those images and at least understand them, even if they don't do the ultrasound themselves. And then, of course, if there's something that just doesn't smell right, find yourself some second opinion. And those second opinions are available around the country. Yes, sir.
When you're looking at the images of the ultrasounds, is there a way you can tell what level you're at? There's no structure that's identifiable there,
There are structures there. So the levels in the neck are, level 6 is the central compartment of the neck, which is inside the carotid arteries, okay, between the two carotid arteries. That's level 6. Level 1 is under the chin. Levels 2, 3, and 4 are down the neck. And those ones obviously morph into one another. 2, 3, and 4 blend into one another. There are actually anatomic structures that define it, but they don't show up easily on the ultrasound. So you're totally dependent on the ultrasonographer who's doing it, saying this is level 2, this is level 3, this is level 4. And again, working in a system where we have collaboration between surgeons, radiologists, endocrinologists, where we actually sit down in our tumor boards and look at the images together, we train one another to do it right. But unfortunately, if you're talking about a community practice where the endocrinologist in one office and the radiologist is across town and the surgeon's in yet a third office somewhere else, it's harder to get that kind of connection that allows that to happen. So you're kind of at the mercy of the guys who are doing it.
I think that the team approach for a lot of medical centers, whether they're a hospital or a doctor's group, I think the team approach is on the rise for that very.
Absolutely. Absolutely, and surprisingly, teamwork works.
Do you do your own ultrasounds?
I do my own ultrasounds for the thyroid gland, but I give over the neck ultrasounds to the radiology group. And the reason for that is that they have technicians to do that ultrasound who will spend as long as an hour, if necessary, measure every single lymph node, record it, note the measurements, note the characteristics of it, and then be willing to go back to the previous ultrasound and compare them side by side. And that's the level of detail you need if you're going to do proper post-operative neck ultrasound monitoring for thyroid cancer. A quick ultrasound in the doctor's office, not going to hack it. And I don't have the time in my busy practice to dedicate that hour of my day to measuring every single last lymph node. And quite frankly, I'm not as good at it as the technicians are. So I defer that out to my radiology group. But we work very closely with them to figure that out. Yes, at the back first and then here.
How long do you typically see antibodies?
It's a variable feast, but often you'll start to see those antibodies fall in the first year to 2 years. If they're persistent beyond 2 or 3 years, chances are you've got some real residue of cancer, but it's not a guarantee and you don't always find it.
And is the Thyroglobulin LCMS titer? Is
That's the assay I was talking about, the
right.
mass spec assay.
Is that accurate when you have the antibodies?
Yes,
So
that's the one that's not dependent on the antibodies. Is a good alternative.
So it's a good way to measure. Okay.
Correct. It's more expensive. It's not quite as sensitive, but in the presence of antibodies, it retains accuracy.
Thank you.
Yes, ma'am at the front.
What's your take on tall cell variants in terms of recurrence?
Tall cell variants, a bit like BRAF actually in the same way, tall cell variants have a tendency to be a little bit more aggressive, a little bit more advanced when they're diagnosed. But once you take account of the stage at diagnosis, it pretty much falls out of the equation.
Okay,
So,
thank you.
okay. So I think we're one more and then we're out of time. Yes, sir.
Comment and a question. A comment about the endocrinologist and radiologist. I go to UPenn, and my endocrinologist, even though it's a big system, a bunch of ultrasound centers, she has her specific group of people that she wants
Yep.
to use. And so, it's check with your endocrinologist. You can go to the head of the endocrinology department and say, who are your best techs?
Yep.
The question, it seems like the sense I'm getting now with thyroid cancer is we should treat it in one sense like diabetes, that it's a disease, you have it, you're going to have it the rest of your life, but you can you follow the protocol of you take the suppression therapy stuff, like Thyroid, you get periodic testing, and you accept the fact that it's here, you can get on with your life.
I think that's actually a very healthy attitude, and it's certainly one that I encourage in all of my patients, is to view this as something they live with. I call it a life sentence, not a death sentence. You live with it for much of your life, maybe the rest of your life, but it's not going to kill you. And so in that sense, very much like diabetes or high blood pressure. Yeah. Correct. 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 And again, I would emphasize that attitude, that approach is something that is beginning to spill over into other cancer types as we get better and better molecular testing and high sensitivity tumor markers. It turns out even cancers like breast cancer almost certainly behave much the same way as thyroid cancer does. So again, appreciate your attention. Thank you very much.